Welcome, everyone, to today's webinar, Creating a Culture of Health, the Interplay of Social Determinants of Health and Medical Care and Why Health Systems Must Adapt, presented by Springer Publishing Company and featuring Dr. James Knickman and Dr. Brian Elbel, the editors of the 12th edition of the acclaimed textbook, Jonas and Kovner's Healthcare Delivery in the United States, which published at the beginning of 2019. My name is David Diadana, and I am the senior editor responsible for the health administration and public health publishing programs here at Springer Publishing. For those who do not know much about Springer Publishing Company, we are an independent publisher known for innovative textbooks, professional references, and clinical products in the fields of nursing, behavioral and health sciences, and medicine. Before I introduce the presenters, please note that this webinar will be recorded, disseminated, and posted on our website in case you missed any part of the presentation. And we will also be taking a few questions at the end of the presentation from the audience and through the chat room feature on Zoom. Please feel free to send along any questions as we go during the presentation itself. I am pleased and honored to introduce the presenters, Dr. James Knickman and Dr. Brian Elbel of today's webinar. Dr. James Knickman is the Robert Durzin Chair in Public and Health Affairs at New York University, with joint appointments at the NYU Wagner School of Public Service and at NYU Langone Medical School's Department of Population Health. He has served many roles both as a researcher and a leader in philanthropy to advance the use of public policy to improve the American healthcare system. Previously, he was vice president at the Robert Wood Johnson Foundation and president of the New York State Health Foundation. He has a PhD in public policy analysis from the University of Pennsylvania and did his undergraduate work at Fordham University. He serves on the board of directors at 3 nonprofit organizations. He has been an editor for 5 editions of this textbook. And Dr. Brian Elbel is an associate professor of population health and health policy at the New York University School of Medicine, where he heads the section on health choice, policy, and evaluation, and at the NYU Wagner Graduate School of Public Service. He is the Assistant Dean for Strategic Initiatives in the Office of Science and Research at NYU Langone Health, and the director of the NYU Langone Comprehensive Program on Obesity. His work uses behavioral economics to understand health decision-making among vulnerable groups and the role and influence of public policy on these decisions. Dr. Elbel earned his bachelor's degree from the University of Texas at Austin and his master's and doctorate in health policy, health economics from Yale University. Here's a reminder of today's agenda. And with that, I will now hand the presentation over to Dr. Knickman so he can discuss creating a culture of health and the changes we are seeing in the US health system. Jim?
Thank you very much. Brian and I are really pleased to be here today to talk about some of the emerging forces that are attempting to reshape the health system in the United States. We also hope to use this as an opportunity to discuss how all this affects what we teach, how we engage students, and how best to use the healthcare delivery in the United States to do this. I've been fortunate over the past 3 years to, as part of my research program, to be working with the Robert Wood Johnson Foundation to really track what's been going on in the health system related to some of these new forces of getting them to rethink their mission, rethink exactly what they focus on. So I've had a good seat to watch this and just want to go through some of it. And then also we're going to turn to Brian to talk about one specific example. So let me start just laying this out. You know, we're really witnessing, I think, a huge effort. We'll see if it's successful or not, but we're witnessing a huge effort to rethink the goals of our health system in the United States. The old focus, the one that I was surely trained to understand and have taught traditionally, is that hospitals and health systems are about delivering effective and efficient medical care. And perhaps they're about advancing new treatment methods to be innovative in how they manage medical care problems. And that's sort of been the bread and butter of the health system in the United States, and we try and make that better all the time. But the new focus is a broader one. It's sort of pushing health systems to redefine their mission, to be more focused on improving the health for everyone in a community. So rather than just focusing on medical care, to say what we're really trying to do is produce health and well-being. And this involves, the new focus involves recognizing that health problems are not just caused by viruses or, you know, things that go wrong in your body. Health problems are caused largely by social factors, all the way we live our life, our status in life, our poverty, all the factors that define how we use our time and how we address well-being. So you need to think more broadly. And then there's a third one. Can we go, the third issue that is part of this new focus is becoming a leader of community efforts to improve health and well-being, to work with other groups in a community to address some of these broader social needs. So now let me just sort of again introduce what we're hoping to accomplish today. First is to introduce this idea of population health and culture of health and these new ideas. Um, and I'm going to go through that. And then we want to go deep on one topic. It's interesting. Hospitals have a good idea of how to do heart surgery or how to take care of diabetes, but now they need to think about, how do I address obesity in America? How do I, be a positive force at getting people to eat and exercise appropriately? And Brian's going to take us through an example of how that works and where that takes us. And then, of course, we want to talk about the meaning of this for educating future leaders, and point out briefly some of how our text goes about trying to help on this regard. So, what's motivating this change, this movement towards a broader mission for health systems? Well, first, it's the age-old problem of high medical costs in the United States. We've always been working ever since I got into this field. We've been working on ways to reduce healthcare costs, to do things more efficiently. And now there's some innovative thinking about really how you might go about reducing spending and redirecting resources. And part of this is driven by research. Actually, Brian has been involved in some of this research, comparing the United States and Europe. And we've always known that Europe spends a lot less on medical care and actually has better outcomes that are health related outcomes. But it turns out that they spend a lot more on social programs, that is addressing these things we call the social determinants of health, like having, addressing issues around poverty, addressing issues around time off from work when you have children, a whole bunch of investments that maybe help people lead healthier lives, and can focus on well-being. So that research has really sparked some rethinking in the United States. And then finally, there's the emerging belief that we need collaboration across sectors. We really want to have healthy communities, really want to keep people healthy. We have to have the medical care system, the public health system, the social service system, and government and public policy working together in multi-collaborative partnerships to really bring this about. You can't make progress probably on improving health with just one player. You need multiple players. So what are the drivers here? How are health systems being pushed? What exactly is happening out there? First thing is there's the Affordable Care Act. And part of the less talked about elements of the Affordable Care Act was really mandating payment reform and really pushing for efforts to get more integration, more coordination across different types of providers. So people didn't just leave a hospital and not know where they were going next. So there's been a lot of push on that. Places like the Center for Medicare and Medicaid Innovation, the Patient-Centered Outcomes Research Institute, and various other parts of the Department of Health and Human Services have been quietly working on some of these issues and funding things like the DSRIP program and Medicaid and many things like that, and value-based payment, which are changing the focus and pushing towards this new view. Second is philanthropy. There are a number of philanthropies that are really pushing this topic because they'd like to see health improved and they'd like more focus on health equity. Robert Wood Johnson Foundation surely is one. They've developed this thing. A lot of it has us have a hard time defining it, but it's this notion of a culture of health. They would just like to see a lot more energy invested in America to help people lead healthy lives and to stay healthy. And so they're pushing that agenda. The Kresge Foundation is focused on health equity and looking at how communities can create more equity to get better outcomes for vulnerable populations. And then there are a range of state-based conversion foundations that are funding a lot of effort at funding communities to invest in some of these initiatives. And then finally, pushing this agenda is an active set of advocates and technical assistant organizations. There are a lot of players, some of them funded by these foundations or by government, that are pushing this topic. organizations like the Democracy Collaborative in Washington, the Center for Community Investment in Boston. The American Hospital Association is pushing this agenda. America's Essential Hospitals, which represent and are association of the safety net hospitals. And even here in my city, the Greater New York Hospital Association has hired a whole staff to help health systems get engaged in this question. So there's a lot of effort to help push this agenda. So is anything really going to happen here, or are there any indicators of change? Let me just throw out a couple of them. Well, first of all, if you think of health affairs, which is an important communicator of new ideas in our field, 5 of the past 12 issues have focused on this issue of population health or community health, keeping people healthy. In the most recent edition, there's an article on gentrification and its effect on health outcomes, the impact of homelessness and its effect on hospital use, and better use of streets to promote physical activities. These are not the type of articles that I used to read in health affairs 20 years ago. So you can just see the changing interest of the research field and the policy field in these issues. Metrics from my own research, we've measured that there are now 8.7% of health systems have made substantial or meaningful financial investments in social determinants, just investing in real programs that address some of these social factors. The frequency of articles about the topic is increasing monthly in the popular press, in the health press, in journal articles, including Health Affairs and JAMA and places like that. And as I've said earlier, the hospitals and physician associations are pushing it, and hospitals are hiring staff increasingly to work on community health. It's not unusual anymore for a hospital to have a vice president for population health or for community health. So we're seeing this new alignment of forces here. And then finally, there's activism at all levels of government. Federal, state, and local are all pushing for this new view of the mission of health systems. So this is what this PowerPoint does is really talk about sort of some of the key concepts here. And one is that it's trying to make health systems think of themselves as anchor organizations in a community. These organizations have a lot of purchasing power. They spend, where's my note here? They spend $780 billion a year across the country in buying services and equipment and supplies and all of that. That's a lot of purchasing power. If you can focus some of that on the community you are engaged in, you can have a big impact on employment and on just sort of purchase, just sort of economic activity in the community. You can hire, you can also use your assets to invest locally, as I say, we've been seeing. You can be key partners in multi-sector collaboratives. You can, work with other organizations to collaboratively address these improvements in health and well-being. And then finally, you could be an organization that focuses on the whole person to improve health and well-being, and not just on the medical care problem they come to see you about. Now, how is this going to affect the health workforce, which gets to the issue of how we teach? One important thing is that the people we educate need to understand this new view of the health system. That's going to be crucial as they go into whatever jobs they go into across the field. And health professionals are going to need to address a broad range of needs that people have, both medical and social, and also behavioral, how they make personal choices that it can affect their behavior. And finally, health professionals need to be comfortable working collaboratively with people in other types of organizations. And it's interesting, I think nurses and physicians have spent a lot of time over the last 5 or 10 years to learn how to work more as teams. And we're going to need nurses and physicians to reach out and be able to work with social workers and with housing advocates and things like that to really get at this broader perspective. And now, so that's sort of the preview of this, or the overview of this. I'm going to turn to Brian to really talk about some of the work he's been doing sort of from the lens on obesity and public policy.
Thanks so much, Jim, and thanks everyone for being here. I thought I'd go a little bit deeper into some of the obesity and public policy work that we've done, and really as a good example about how social determinants within healthcare can really inform some of these broader population and policy-oriented approaches. So many of you might have seen these maps. This is going back to 2011 from the CDC, going up to 2017, and as you see, the colors get move from green to yellow to orange to even more dark orange. You see probability of anyone being obese, population level obesity rates really going up. And it's been this huge dramatic increase over time. And I think we're still very much getting a good handle over what this means and what we do about it. It's true for kids as well, right? This is differences. It's true for kids as well, both in terms of the fact that it's been going up for the most part, and also that there are some big disparities, right, between non-Hispanic, white, Black, Asian, and Hispanic populations, right? Some really big differences there with some higher obesity rates with non-Hispanic, Black, and Hispanic groups as compared to Asians and whites, and some key differences between boys and girls as well. So, how might we think about obesity in a broader population health way, to both related to health systems and related to culture of health more generally? And a lot of my work on that really does focus on public policy and does think about how we can influence behavior in a kind of a large scale way, not a necessarily one on one, but a broader way. And really the classic example of this, and particularly something that has worked really well over time, is smoking, right? You know, we've seen smoking rates go down pretty dramatically over the last 30, 40, 50 years for the most part. This was largely because of public policy oriented approaches like taxes and indoor air bans. Now we have a whole additional issue of e-cigarettes that we could talk about later in the Q&A if we have time. But a big focus of our work is really looking at, all right, might these same kinds of approaches work for food choice, work for obesity, and the same way work for smoking? So there's been a number of public policies that have either rolled out or been attempted. This is alluding to sugary beverage taxes, soda taxes, which ended up not passing in New York, but have passed in many other locations and is a big public policy potential. There are moving new supermarkets into quote unquote food deserts in low income or high need areas. This is one that we studied. I'll tell you a little bit more about in a second, in the South Bronx neighborhood of New York City that opened because of city tax credits. Another big one is thinking about marketing and marketing to kids in particular, and who doesn't want a Pop Tart Barbie, right? This is something that we know really is highly prevalent. Kids see a lot of these ads. They're almost all for unhealthy foods, and it's a big part of policy focus in other countries. It's one we have a harder time doing work around in the United States. I'm going to talk to you a little bit about menu labeling, the requirement that menu labels go up on fast food restaurant menus. Mayor Bloomberg in New York City at the end of his term tried to pass what was called the big gulp tax, even though it didn't impact big gulps, but essentially influenced big sugary beverages. So I'll tell you a little bit about work we did to look at the potential impact of those sorts of policies. And the last one is really kind of counter marketing, right? This is what work that the New York City Department of Health has done to try to bring attention to the potential negative impact of sugary beverages in some of these things. So again, the real question is, does this work, right? Is this something that might have a broader influence on behavior? So again, these policies range the gamut from information provision, stuff that's happening in schools, marketing, pricing, food availability. Many of these are what we think of as more kind of big P policy, laws or regulations that happen at the city and state level. Increasingly, however, you're seeing more little P policies, organizations that are making rules and regulations. And I think healthcare organizations and hospitals are a key component of this, that kind of regulate things or have particular provisions around what happens on their campus as well. So really briefly, a couple of our examples, right? This is some work we did looking at the influence of public policies around menu labeling. You see, and basically any fast food restaurant you go to in the nation now, that's at least a chain restaurant, the number of calories up on the menu board. We did some work in New York City, both looking before, right after, and a few years after to see, are people seeing this information? And we found that a good chunk of people, if you look at that top red bar, actually are, right? Right after labeling happened, over 50%, declining over time, but still upwards of almost 40% of people said that they saw this information. What we didn't necessarily see, though, is any change in the number of calories purchased over time, right? So it isn't a policy that where we saw these sort of huge swings, although now we are going back and looking at some of this on a more kind of detailed individual level and seeing if we can see changes as this policy has rolled out nationally, not just in New York and Philadelphia, the two places we've studied it thus far. I mentioned at the beginning this new supermarket that opened in the Morrisania neighborhood of the South Bronx. It was nice. It had lots of local produce. It had stuff that was culturally appropriate for the neighborhood. It also, like all supermarkets, had a bunch of less healthy food that you see in the middle aisles of supermarkets wherever you go. And we did some work to look at did the introduction of this policy and the subsequent supermarket that was put in this high need area and this food desert actually change people's consumption or purchasing behaviors. And we found that it didn't, right? At least for the kind of the broad community as a whole. But when we zoned in on the area just around the supermarket, we actually think we do see something of an impact there, which makes some policy questions harder. But we do think there's something of an impact when you really get very, very local in terms of these approaches. So the last couple things are thinking about some more deeper dive work we've done in New York City. The map you see on the right is every New York City public school kid, where they live and what the obesity rate in their neighborhood is. And you see big variations from less than 10% to over 20 or 25% of the kids within a neighborhood at census tract in this case are obese. We can really combine that with other data about the availability of food stores. This is a dot representing every food store in New York City, whether it's a fast food place, a supermarket, a bodega, or a corner store. And we can link those things up with kids' obesity rates and where kids live, and really look at what the influence of having these stores really close around you might be. And just to kind of give you a little snippet of this work, we actually do find that if kids are living really close to fast food places, it does increase their probability of being obese. And just getting a little bit farther away, whether it's a half a block, 1 to 2, 2 to 3, you can sort of help them from a health perspective a little bit more. So again, we're doing some work looking around schools as well. Many of you might have seen this cover of the New Yorker magazine as Mayor Bloomberg was trying to pass the large soda policy, seeking to a corner to drink a big sugary beverage. This almost passed in New York City. This is what Dunkin' Donuts was giving out before the policy was going to be into effect, describing it and what it meant. We did some work trying to understand what impact this policy might have, and actually found that it probably would have had a potential impact here, although in a much more restrictive policy, right? This is not just putting information up. This is actually kind of really making something harder to get in a bigger picture way, but likely would have had some sort of impact. So we have a lot of these public policies that are happening at the population level. Some are promising, some aren't. None of them are going to be enough, and we need a lot more work on what's happening. And I think we really do need to understand both just sort of not just the big P policy, but the little p policies and how these are increasingly rolling out as well in a number of different localities, and a number of different employers are making really important decisions about this that could have a large, bigger picture and cumulative impact as well. So we're just going to do a little bit about teaching population health as well and give you some sense of that. But first, we have one quick polling question as well. And this is as an instructor, right? How you think about population health within your coursework. Are you currently addressing it? No, and don't have plan to introduce it in the next year, or you think it doesn't necessarily apply to the kind of work that you're doing? So we'll give people another 5 or 10 or 15 seconds for this one. All right, we see that the vast majority of people are currently addressing it, and those that aren't are either planning on it or it doesn't apply. So I think there's some traction here for some of this work. All right, and then in terms of teaching population health, right? We wanted to give just a few broad ideas here for how this might work and how to make it work a little bit better. And a couple just sort of tips and indicators here, the things that we've seen work before, heard from colleagues, is really being clear about these definitions. A lot of these things involve terms that people have some sense of, but are often used very specifically in some of these fields, or people have different ideas about what they mean. So we think that's a really important component of this as well. And really think about how different fields, different health professional fields, are addressing population health. Many people are coming from a very different starting point. We need to think about how evidence-based population health models and examples are working, and really use those as key drivers of some of this discussion, and ways that people will realize. Many people kind of understand tobacco policy as a key indicator here, and really also thinking about how social determinants can really think about, and using that as a framework for thinking about some of these broader population-based interventions and policies. And that is something that the book really does take up as well. And then finally, it's to think about having students really think about and analyze the benefits and challenges for healthcare organizations as a whole. Where are they starting from? What are the key provisions or benefits that people are starting from and these different organizations are starting from that make addressing some of these approaches easier or harder, I think is another big key part of this discussion. So I'm now going to turn it back to Jim to talk about a little bit about how the kind of newer text that we edited versus the older text combines and compares here.
Thank you, Brian. Yeah, so it's interesting when I go back to I can't believe it's been 5 editions, but when I go back to this, I guess the 8th edition or 7th edition, when I first started getting involved in this, if you looked at the text, most of it was about medical care, divided up into different buckets of types of medical care or types of things that health systems have to deal with. In terms of that, there might have been a chapter on public health, I think, as one thing. But now, over the years, again, partly pushes from the folks who use our book, it's been more restructured to take a view of the role of health policy in shaping some of these questions and shaping how we invest resources, and then looking at the issue of keeping Americans healthy. That's actually part 2 of the book. And it isn't until part 3 of the book that we get to the medical care system, how to treat medical problems. So in some ways, we talk about the the infrastructure to keep people healthy first, health policy and the issues of population health, public health, health and behavior, and vulnerable populations, and then we go into medical care. So I think we've set it up so that you can address these and see how one leads to the other and the interplay between them. And especially this chapters 5, 6, 7, and 8 are really focused on these topics specifically, but also our chapter on politics and dynamics of investments in chapter 3 and the chapter 11 on healthcare costs and value really get at the interplay a lot. So I think there's a fair amount of content there. And then there's also case studies at the end that more often focus on the interplay among determinants of health and medical care. So there's just a lot more there to whet professors' appetite to address these questions, and we hope it's all helpful. Yeah, and with this slide, it really points out the chapters that really focus us on these issues specifically.
So we thought we'd go a little bit into some of these best practices about how we've heard some of the instructors are using some of this new material, and particularly some of the kind of newer chapter features and ancillary materials that are there as well. And, a big one is we now have test banks that are important, we think, for helping you to kind of develop some of the content here and that are helpful for your assessment. We have podcasts that are there on Spotify, on Apple, on wherever you get your podcasts, wherever your students get them, they can go. And that also provides a really nice set of adjunct and additional materials as well. The other thing we've really tried to look at is really making these figures be able to really tell the story and let them be there for you to help within your teaching and reinforcing your teaching as well. I think a good example, as you see from all these are quotes from the first one, looking at really the county health rankings and how that was a driving factor for some of the teaching there. So again, we really do try to have this material to make it as useful and straightforward for you all, and also to really also make sure that we're giving you materials that you can complement and really reinforce in some of your lectures as well. So we would love to answer some of your questions, right? And so we're going to open some of those up now. So please start writing in if you haven't yet, and we'd love to answer as many as we can.
Question number 1 is there any movement toward public policy on providing exercise programs or effective weight loss strategies? For example, Weight Watchers International or Girls on the Run programs. Subsidies or promoting these could truly impact the health of many.
So it's a great question. And I would say the most attention we've seen on that has really been in schools, and more cities, states, localities are starting to really require physical education within the school system. And I think that that's a really important thing. And there has been some really nice evaluation work that has shown that something like that actually could be really helpful to kids' obesity rate and overall physical activity. We've seen a little bit less action on it in a broader outside of school way, although you do increasingly see employers trying to do these wellness-based programs where they do subsidize some of these types of approaches that you're describing. I think the evidence on these is fairly mixed, with a lot of newer evidence pointing towards questions about their overall usefulness. So I think we still have some overall work to do, but some of the bigger ones that you're mentioning actually are the most evidence-based, where we feel like there could be the most impact from. So I think that that's still really an emerging literature and evidence here as well. Great question.
From Harry, I work in a nonprofit hospital. Where do you see the most investment in population health initiatives in all hospital systems?
So it's interesting when you think about health systems, they have a lot of, they often have a lot of cash assets, sort of uh, and what other places might call profits, but here they're really net assets that are there. And so the question is, how do hospitals invest them? And when you look at how much of, as I mentioned earlier, about 9%, 8.7% of their investments are now, addressing these. And the most frequent one by far is investing in housing, supported housing, even sometimes shelters for homeless people. And it's interesting. That's makes sense as an early investment in social determinants, because investing in housing is a concrete thing. You put your money down and you build something, and it sort of achieves some social goal. It's also true that investing in housing is one of the areas where there's a greater chance that you'll have a return on the investment. If you build low income housing, you can rent it, you might make profit, you might be able to sell it to somebody along the way. So the first type of investments health systems would like to make are ones where there is a chance of having return on investment. And so I think that's where we're seeing housing is one. But others have invested in food banks, setting up their own sometimes, or making contributions to them. They've invested in transportation to get people around, because a lot of times that's a real barrier to getting services that they need, both social services and medical care services.
I have a question that speaks more to the book and its contents. How does the book cover or integrate topics such as diversity, immigrants, community health clinics? And this is from Suzanne.
Yeah, I guess it was last edition, we added a chapter on vulnerable populations. And chapter 8, I think it is, and that chapter really gets at this question of health equity and how do you address the needs of the most vulnerable. And I must say, if you think about population health, it's people with serious diseases and people most vulnerable in our country, low income people, people who are homeless, that lead to the highest expenditures and the worst health outcomes. So those equity questions, I think, have to be front and center, not only because they're morally the right thing to do, but also if we want to have a healthy nation, that's where the attention should be placed. And I think that chapter lays out this issue. It's written by people who are really passionate about the issue and are really working deeply on the issue. And I think it sets up the ability to have a good discussion about it.
And the other thing I think I'd add is that it really covers a broad range of these vulnerable populations, right? So it's the kind of traditional groups, immigrants, and those that you mentioned, but it also thinks about urban-rural differences and a whole array of potential differences that ones that arose because of economic recessions, et cetera, and how we can really think about addressing those within the healthcare system overall.
I have another question. What are your thoughts regarding implicit bias and the impact it has on healthcare delivery within our healthcare system? Are there any suggestions on addressing this in education, as well as institutional or structural racism and its impact on social determinants of health and healthcare delivery?
That's a really great and really loaded and really important question, right? So I'll give a couple answers. I think that I think there's sort of maybe two components of that that are most important to tackle. I think one is the kind of broader structural racism question and components to this, and I think that's something that some hospitals and health systems have been very slow to open their eyes to. I actually think that it's something that we need to do a lot more with. I think it is something that you see emerging a little bit in the broader kind of policy sphere, if you will, and trying to really understand how many policies do have a broader structural racism component and what that really means. I think the kind of second important component with respect to thinking about health systems and population health and health policy in general is the kind of implicit bias stuff you mentioned, where you are starting to see a little bit more of an awareness for something like that. It's really played out in a bigger way nationally in thinking about maternal and child health outcomes, differences in women's of color experience giving birth to children, and the kind of real outcomes and how both structural racism and implicit bias might be a factor in some of that. So I think it is a really important component here, and I think it's one that maybe the healthcare system's a little bit slower to being able to adapt to than some other fields, but I think we are making some progress in that.
And it's interesting too. I think universities are a place that has worried about implicit bias more than others. I mean, there are seminars here at NYU. There's mandatory, learning that we have to do, and maybe we need to take that on the road and make sure we're teaching that to our students and pushing it to other environments like health systems too. And I'm not sure we've done as good a job on that as we could.
The next one, I had the 6th edition of this text in 2000 during my graduate nursing program. It provided an excellent review of healthcare payment systems and didn't seem to lean one way or another politically. In today's climate, does this text still present material in an unbiased manner? Do you find this text to be geared towards one specific profession, so nursing versus medicine, or graduate versus undergraduate?
It's interesting. Our textbook is sold all over this country in red states and blue states. And we really keep that in mind, that this is not ideological. And we try to keep balance. And a lot of these issues are not political. They're technical, and they're about improving effectiveness and efficiency. I think some of our authors have points of view that come out, and I think professors have a good role of modulating that in some ways. So I think that's an important thing. What was the other part of the question? Was
About different fields.
different fields. What's interesting. Surely when this book was first designed, it was for, schools of health administration, health management, maybe public health, but it had a more target there. We've realized over the years that there are so many professions that play leadership roles in the health system that sort of blend service delivery and management, nursing in particular, but almost every part of it, dentistry, is interested in how we improve the organizational part of what we do. So we have broadened the book as much as possible to say the issues are pretty much the same, whether you're a nurse manager or you're a financial manager. You have to understand these concepts. And frankly, a lot of nurse managers end up being CEOs. So, and a lot of finance people end up being CEOs. So you have to think about the long-term career of people when they're in programs like we teach them.
From Brenda, thank you for adding the content on vulnerable patients. It was much needed, and I use it to add extra articles on this topic when using the previous edition. What are your thoughts on adding more robust content on health illiteracy? I think this is an important topic, along with making sure patients understand they are the most important part of the interprofessional team.
Great question. And I think we probably get at some of that in the chapters around sort of behavior change and health behavior work. And I think that we haven't exactly totally pushed it from the frame of health illiteracy, but I think it's inherent in some of that. And I think we could think about that more. It's really great to actually get feedback from folks about how they're actually using it in their classroom to be able to think more about that. So I think the kind of broad sense of that content is there. And I think we could even think more about some of the frames you're describing.
From Deborah, I know it is difficult to cover health various professional leadership in changing practice in the community and in a hospital or health system to change policies. Is there a possible way of strengthening this, or do you have suggestions on how to address this?
I think one of the I think one of the easiest ways, most straightforward ways would be to use examples from your own work and your own environment or that you know of where you've seen these various sort of leadership things happen in very different ways from people coming from very different fields. So I think that would be sort of one of the most immediate suggestions. And I think we could even think about that. Some of those kind of case studies or examples for future editions of the book as well. I think that some of those can make them very real to students and also give a more local flair and flavor. So I definitely appreciate that suggestion.
Eileen wrote in that she has a little disagreement amongst her colleagues. Can you comment further on the ROI and outcomes related to population health versus personalized medicine?
What a fun topic. I think that there's just to give a little background to this, right? I think sort of what the questioner is referring to is this idea of should we be kind of attacking population health in a bigger picture way that we think is going to work for everyone, or is this going to be more about individualized treatments and approaches that are going to really kind of hit at people in a more individual way, where you might have different risk factors and different things that help you. I would love to hear some of your debates about this, right? How I've been hearing it play out with some of my colleagues has really been about right now, there's probably a lot of value in going after these broader population health based approaches that we think are going to work broadly. And I think the science will probably catch up eventually where we're going to get there with some of this personalized work as well. I think the other thing that I would do to kind of flip the script a little bit is there's increasingly a movement for things like personalized population health, right? How can you really think about maybe not what an individual needs, but what a community needs and really kind of target it from that perspective as well. So I think in some ways these fields are converging a little bit as well, and we may get even more convergence over time.
It's interesting. I think where you need to be working on both ends of the health sphere, if you think about it, and one end is keeping people healthy, as we've been talking about today, but there is amazing technology emerging out there. And let me just say a little bit in either one on each of those. On the return on investment part, there is more and more. There's been a lot of investment in research to understand what things have a return on investment or not. And I personally do a lot of research on the Medicaid program and looking at the interplay between social services and medical care. And we are finding a number of social service programs that are keeping people out of the hospital and keeping people out of the emergency room, keeping people more healthy. So I think there are some returns on some concrete things. I think there are returns on getting people to exercise more and eat better and stuff like that. On the other end, though, I think the personalized medicine is really interesting. It will help some people, probably fewer in volume than if you could get people to eat healthy, but it will help people. But the other thing that is a challenge in healthcare is going to be a lot of the emerging technologies are almost going to be prevention oriented, like tweaking your genes in order to reduce the chance that you have a heart attack or you reduce the chance of getting diabetes. Um, and and an important social question is going to be, do we consider those things that are funded by insurance, or are those going to be out of pocket things that only wealthy people can afford to purchase? And that these will be important, social decisions and discussions, I think, over the next 10, 20 years.
Also from Eileen, given the need for applied numeracy in each of our fields, do you have plans to include access to data sets for quantitative exercises or even add mini projects with instructor guidance?
That's great. And as a quantitative person myself, I appreciate that. I think it is something we should think about for future years, right? It is something that I know that I've used in my own teaching and some of my colleagues as well. So I think that is something we could really think about. I think the challenge would be to sort of cater it to the right level, given that there's students are coming at this from a big differences probably in terms of their kind of quantitative expertise coming in, but it doesn't mean that it's impossible to do. And we do try to at least make understanding data and being more numerate with the kind of data you read and understand a big part of the book this round as well.
From Teresa, I think mobile health and telehealth is a great way to encourage and assist people with their healthcare goals. How do you see this in the future, especially if made available to the at-risk population? I believe prevention will pay for itself.
That is an interesting element of the changing health system. A place like Kaiser Permanente in California, they have a goal of getting to be over, they want to have over 50% of their encounters with people to be by telephone, telehealth, or email. Because it's takes so much time and energy for people to get to the doctor, and it's more efficient in many ways. So I think that, and with apps and ways of communicating back and forth, you're going to see more and more of that, and I think it is a positive thing. I'm doing some research on how telehealth helps the intellectual and developmental disability population, and these folks often are taken to the emergency room when just a phone conversation could have taken care of their problems. So I think I agree. There's a lot of potential there.
Also from Lewis, what current proposed policies are there to decrease drug prices? And out of them, what do you think are the most feasible?
Well, that's a tough one. Some people say the best way of reducing drug prices would be to have national financing of political campaigns because the drug industry, invests so much in lobbying and things. But even the Trump administration is really trying to address this issue and trying to sort of have Medicare maybe start negotiating drug prices, or have some maxes, or pin them to what the Europe is paying, and so on. So this is being actively debated, but again, I think there's a twin forces of there's an awful lot of money being made, awful lot of jobs in America that are pharmaceutical related, and that's always a challenge to push public policy.
Yeah, it is one of the few public policy debates related to pricing or access where you actually do see some agreement on both sides of the aisle. So we'll see if anything can come of that to overcome the industry pressure that Jim mentioned.
From Matthew, what industries do you see the most resistance to change in policy in order to combat obesity?
So pretty much anyone that makes food is trying to combat some of these policies that work on obesity, right? A lot of the target of products has been in sugary beverages, and so that's where you've seen a lot of the kind of broader pushback from some of the companies that make these sugary beverages. So I think that's there, and that's prevalent, and that's a big part of it. I think another really important way to think about this is what happens internationally in other countries as well, because you increasingly see kind of a clamp down here that may then be kind of coming back in other countries, right? So I think that's another really important part of it also.
So I just have a follow-up question for Brian. Can't you make money if you're a food producer on good food as opposed to bad food? Why isn't there substitution here?
Yeah, so it turns out that most of the foods that you can make the most money from and that you have the highest margin from are ones that are most processed and less bad for you. So, it turns out, supermarkets can make some money from selling fruits and vegetables, forgetting about the time cost of people preparing them, but they actually are ones that are the highest cost for them to procure and to take good care of and to keep cold and all those sorts of things. So there is something of a push in the other direction. But if you look at a company that's selling sugary beverages, if everyone who bought those same sugary beverages switched to kind of less sugary beverages and they still sold, you could maybe still have some win-win. So there are some ways you can do that.
And from Jennifer, what are the biggest barriers to creating a culture of health? How does it work with the triple aim?
So well, first of all, the culture of health is a very broad concept, right? It's saying, gee, we have to address health equity, we have to address eating, we have to address tension from work, whole series of issues. So, I mean, part of the thing of achieving it is it's a whole. It requires a whole change in mindset of what we think is important in our society, and not just at the individual level, but also at the social level, in terms of what the priorities of government should be, what the priorities of our community should be. And so it needs to engage a whole set of people. I also think that the culture of health might be one of these things where there could be a tipping point where like we saw sort of in crime in America and in big cities and stuff, it was terrible, and then it got much better. And the same thing with use of crack and cocaine and things that sort of got better quickly. So I think this might be one of the things that you work gradually on, and then you might see real progress. But it takes a lot, and it'll take a long time to change some of the basic culture.
Okay, that is all the time we have for today. Thanks so much to Jim and Brian for being here and discussing the creating culture of health. We hope you enjoyed the webinar. Please visit us at www.springerpub.com/US Healthcare Delivery for more information on the 12th edition. You can get access to the podcast. You can get chapter profiles with authors from the book and Q&As with them. There's a lot of information on that site. And also, please feel free to send us questions or comments through email. Thank you for participating today. Take care, and until next time.